we will start today's session. And today, like earlier, for a 3 or 5 day session, we generally ask introduction from each one of you. But since this is only a 3 hour session and it's only for one day, and I think all of us know each other because all of us are our previous participants, except for few who are new. So I think we should start. So, welcome to all of you to this workshop. And this workshop, we are going to learn the cultural domain analysis, especially the two techniques, the free listing and pile sorting, in the Anthropack. So, this Anthropack journey, this started way back in 2016, 17 when we started learning the qualitative analysis. So at that time, it was, we tried to do it in the DOS version, and we conducted a workshop also, but that DOS version was not very, user friendly. So we stopped using it, and we could not make it further. Like we could not have any other workshop on that. But after that, we explored this window version of Anthropack, which is relatively simple and easy to do. So then we started doing it, and then we planned for this workshop. So initial one session we took in the sixth qualitative uh, health workshop also, which we conducted probably in the February this year only. But at that time, we could not have this hands-on session. So this time we have planned this so that you can learn during the breakout room activity. So for all those participants who are new, I would like to like say some important points that generally this workshop will be of 3 hours, and there will be two breakout room. So in breakout room, this is a small room where there are 3, 4, 5 participants depending on the availability of the mentor, and under the guidance of some person, you will be required to share your screen, laptop or desktop, and then you need to perform the steps which we are showing it here. So once you do it, it's a kind of hand holding. And generally, just lately, we have finished one of our workshop, which was on medical education. And there also we have learned regarding the zone of proximal development. So that zone of proximal development is what, when you hand hold someone where he or she is not feeling confident, then that person becomes confident. So this breakout room activity is one example of that zone of proximal development. When we hold the hand, we try probably, and there's a limitation, but that many of you don't join with your system. Someone is with the phone, or someone is not having a very functional system. So in that case, you can guide us. You can guide the other participants in those commands, whatever we have to show. So I'll start this session. This is the reference book which we have tried to use, although we could not include all the content from this book. We'll share this book to you. This is a soft copy, and it has got a very beautifully written the pile sort and the free list as one of the research method in the anthropology by the Russell Bernard. So in that book only, he has started this by telling a story. So that story was of a Spreadley, and Spreadley was one of the author who has initiated this free listing and pile sorting as a research method. So there was a story that this person named Fredley, there was a theft of two bicycle from his garage at the midnight. So he has lodged the complaint in the police, but to claim the insurance money, he required the case number. So, there's a case number for each case whenever you go and lodge the case. So, insurance company to give the money back required the case number. So, he called up the police and inquired regarding the case number of for that bicycle. But the police said that and he said, when he called up, he said that I want the case number of the robbery. So when he said this robbery, the police transferred his call to the robbery unit. That happens with many of us also. Like whenever we call customer care, then they transfer it from one desk to another desk to rest of the desk. So similarly, he transferred the call to the robbery unit because he said that this bicycle was stolen at the midnight, and robbery definition means that someone, after putting gun and in presence of people, he took out the bicycle. So this definition, the way the person defines, this is not a case of robbery. So he transferred this case to the another this thing called to the robbery unit, because when he said that it is a robbery, he transferred the case to robbery unit. But robbery unit said that this is not a face-to-face crime and there is no threat or use of weapon. So he transferred the case to the burglary unit. So burglary unit, he said that, since this is a bicycle and there was no one present at that time when this was stolen, so he transferred the case to the juvenile division. And then ultimately the juvenile division gave that case number which this person, the Spreadley, wanted. So, but what he said at the end of this activity, that if I could have known the cultural taxonomy of crime, means what do I mean by robbery, what is a burglary, what is a juvenile with this thing, so I could pose the question immediately. I could not have said robbery because he said robbery and then he defined what a robbery is. So that's how cultural taxonomy of anything, and that's how the importance of, he emphasized the importance of the cultural domain analysis. You should know the common terms which a particular organization, how they use, or how the taxonomy of those terms are in that particular organization. So in health also, this was an example not from health, but in health also, we will see there are many uses of these free listing and pile sorting exercise. And this is again a cultural domain analysis which we do in the health. So since I said the cultural domain, so we will first understand what do we mean by this word domain. So if I ask this question, name some fruits you commonly eat. So yes, please write in the chat box. Like, or I can ask like, what fruit you have eaten today? If I ask this question, what all fruits you have eaten, ate today? Papaya, Khushbu is writing, kiwi, apple, banana. Okay. So all these fruits, here the fruit, if I ask this question, name some fruit. So fruit is a domain here. And all the individual item you are listing here, like watermelon, banana, orange, they are the elements of that domain. So you need to define what is the domain. And those of you who are a little, familiar with the qualitative, there also we define domain when we define what we want to measure. And in scale development also the same thing, we define the domain and subdomain. So here whatever item, in the case like we have given this exercise to you people regarding the barrier in the consultancy of the non-communicable disease. So if I ask again this question, what are the common barriers to accessing healthcare? So in this case, what is the domain here? All of you please write. What are the domain here? If I ask this question, what are the common barriers to access the healthcare? Yes? So barrier to healthcare. So you are right. In this case, the barrier to healthcare is the domain. And the listed response, whatever response I'll get, those will be the elements of that domain. So there are two terms. There is a domain and there are elements of that domain. So domain, now what is a domain? So domain is the psychological construct, or it is a type of construct or a specific category that is residing in the brain of that person. So whenever we say such things, that particular area of that brain gets excited and probably that thing comes in that person's mind. So basically it is a related concept or a category, specific category, which is there in a person's mind or a people's mind, because here we will see there is a shared belief and there is an individual belief also. So whatever the specific category or specific related concept that is there in that person's mind or people's mind, that is the domain. Like if I say, why do some people refuse modern medicine, and why the people they prefer for like homeopathy, and they go for Ayurveda and Unani and etc. Or if I ask this question, why do mothers delay vaccination? Because in the immunization program also you will see a lot of people, there's a dropout, and there is a like people they take the first dose and then they don't go. So they reasons for knowing the delay of those vaccinations in their children. Or if I ask this question, like in why if I give this example of institutional birth, so in Bihar what happened, like if you take the data of the first childbirth, so the data of first childbirth regarding the institutional delivery, it is very high. It is approximately 90%. That means for first childbirth they go to the hospital, but for the next like second or third or subsequent, they don't want to go, they prefer home delivery. So if I wish to know the reasons why they prefer, why they don't want to go to the hospital for their second or third child, or if I want to know, and that again, that's a shared belief, because it's a shared belief of the family. So if I want to know regarding uh, like we are doing one project, that is the project Majdhar. So Majdhar is like related to the middle-aged women. So whenever you talk to a middle-aged woman who has completed her family and she's having any complaints, so there is a hesitancy in sharing the symptoms, especially in the Bihar, especially in rural area. They will not clear cut say what they are having. Rather, they will say some vague symptom related to some important, like if there is a prolapse, they will use some other terminology. If there is a like incontinence of urine, then they will again use some other terminology. So we are doing this free listing exercise, we are trying to map what are the symptoms and what name do they say related to those symptoms. So if I want to know, and that's again a shared, because this whole middle aged women, it's a group, it's a kind of a population, so it's a shared, because each one of us listen these symptoms from the other, and the same symptoms, when we will grow older we will also say the same thing. So it somehow it is there in the culture, these terms, because these terms and the words, they are also, how do we learn these? So generally it starts as a family, we are there in the family. If my father or my mother says something, and if I am if I'm a child, I'm learning those terms. So it starts from a family level, and then collectively a set of family becomes a small community or a population, and those terms, there's a more use of those terms which a person who resides outside that community may not be aware of. So if we wish to know such taxonomy or such terminology which is prevalent in a particular community, we need to do this cultural domain analysis. So this cultural domain analysis in health research, so we have seen that example of police system, how the taxonomy is there in their system. So if we wish to do the same in health, so again we wish to know like how people's belief or how their perception or their mental abstractions or framework, they shape the health behavior, like the way they opt or they go for health seeking, or they don't go or opt for a particular service. So health decisions, what is your idea? If I say like health decisions are shaped by culture and cognition, so can you give any example? Can you write down any example to support this sentence? If I say that health decision, it is shaped by culture. Any example? When you see this in your everyday practice, okay, prelactal feed, true. We can restrict ourselves probably to the mother and child care, because a lot of cultural factors are there into the care of mother and child, and it may vary from one region to the another region. Anyone else? Any decisions shaped by culture? Avoiding some foods during pregnancy. Yes, we say like papaya. Someone has written papaya. So they avoid taking papaya because there is a risk of, they think that there is a risk of abortion. Okay. There are many religion probably where this, even the MTP, that is, person cannot go for MTP. Vaccine. Again, there are community where there is a hesitancy for few vaccines. Okay, and then taking homeopathic medicine for hypertension. They prefer traditional healers. True. And in tribal community also, if you see, they prefer more of a traditional healers and the faith healers rather than the a person who has a degree. So because that's there in their culture. So there are many health decisions. Dr. Poonam is writing case with fever and rash, curse of God, people visit to temple. Avoiding healthcare seeking for chicken pox, taking jhara for fever. True. So a lot of and it is not like illiterate people go for this. Even if you see like many affluent society and many like people who are so-called high class society, they also their health decisions are shaped by the culture and cognition. So, like this is again, I think Priyanka has written regarding the traditional versus modern medicine that if my this thing is if I there's a pregnancy, so I may go for a traditional sort of medicine rather than a modern medicine. Or if the example of vaccine hesitancy, because many religion or some community there is a kind of vaccine hesitancy because of some rumor or because of some cases like they will become infertile, or there are case studies related to that. So vaccine hesitancy is also, it is shaped by the culture and cognition, apart from all the other example which you people have given, or around the mental health. So any example which you have seen regarding this culture and cognition, here it will be more of a cognition stigma around mental health. Yes, any one of you who has faced this situation, personal or any relative, where they were having some mental health issues, but they were not going to the appropriate level to seek care? Can you all keep up? Epilepsy. Okay, Priyanka is writing epilepsy taking bhoot pret. Okay, good. Okay, so here also, like many times we, twice or thrice, I face this issue. Like we face this issue in the institute. Like if some resident or even a nursing student, if they are having some issue, some anxiety or some sort of depression, or they are not feeling well mentally. So what they used to say, we don't want to go to the psychiatric department of AIMS. Why? Because then the people will start judging us. If somebody will come to know that we have gone to the psychiatric department, then they will start labeling us as a mentally unhealthy, and whatever we will say, they will not attach due importance to that, because they will say ki, oh, like he's not having a sane mind, or whatever. Even if we are in anger, they will say there is some mental health issue or something like that. So you are very right. It is not only in the case like epilepsy and uh, the kind of you were saying like psychosis in temples, but if you see these days are very normal. A lot of suicide case you must be hearing these days, to the various like kids, to the adolescent, the quota, then even the medical students. We here faced 3 or 4 suicide cases of PG students. So there you cannot say that they were quite intellectual people, got through their empty seats, and in spite of their, because of some stigma around mental health, they did not seek the care. Hysteria cases. So there is a stigma, there is definitely, and it is there in the doctors also. Even doctors, especially the residents who are very new, and the medical students who are very, like, you can say, very immature, not in that context. Immature means like experience wise. They think, they are very afraid of being judged. So that thing keeps them away from consulting a psychiatrist or any psychologist. So and they again say that, and usually when we ask from the students, like why you don't go, because when we ask to the peer students of a person who was suffering from mental health, so they say that, ma'am, we don't want to say this, because whenever we say such thing, our friends or parents, they say ki everything is okay, it will be all right. Nobody has asked them to consult to a psychiatrist. They say that it is very normal, it is a very it is kind of medical studies are such that it is a very it you are maybe taking way too much of pressure or something like that. Go for a walk, or just go outside for 3 days. But they have not asked them to consult to a psychiatrist. So that is very important because they think ki it is like you involve yourself more in the God and please pray more. Again, there are some gender norms in the healthcare access. If a female wants to go to hospital to show herself or for antenatal checkup, she's dependent on the male person. And even if she wants to go alone, in her family, nobody, especially I'm talking of Bihar, things are different in various geographical location. But in Bihar, the female for healthcare, she's very much dependent on her husband or anyone, male person in the family to go to the doctor. And if they are not having time, she will not go. So that's why if you see the antenatal, the 4 antenatal visits or the coverage in the NFHS 5 of the maternal and child health, it is not it is very less as compared to the national standards because they are not that much empowered to go alone to a hospital or to any healthcare facility. So this is again guided by, because at home they will say that you cannot go alone. There should be someone who should accompany, even if it is there with us also. If there is a delay, like if I'm attending a meeting here at institute, and if, like, let's say it is 7 o'clock in the evening, so everyone at home will start calling me up. Please hurry up and just reach home by 7:30 or so, because they consider that it is not safe for me to travel alone. So that is again the cultural belief that a female should be at home. There are reasons for that. Again, I'm not saying that those cultural shaping up of those decisions are at random. Definitely there is some experience, there are some things, some news and all those things which makes them to take such decisions. But these are the decision making things which are there in the people's mind. So if you see the cultural domain, so what is a cultural domain? So basically cultural domain is a shared belief. So it's a set of people which that belief is shared by a set of people or the community, how people view that health. And what is a cognitive domain? So cognitive domain is the individual abstraction, what an individual person is thinking on a particular issue or a mental model. Of course, these cognitive domain together makes that cultural domain. But how the individual mental capacity or individual understanding is shaping the response to the health issues, that's the cognitive domain. So let's summarize. We have learned why there is a need to understand these cultural domain in healthcare, related to various issues, related to the mental health, related to the vaccine hesitancy, related to the health seeking behavior. And we have understood what is a domain. And we have also understood that domain is of two types. There is a cognitive domain. So cognitive domain is basically the individual mental perception regarding the health issues. And then there is a cultural domain. So cultural domain is the shared perception or shared belief or values for the health. So now, why these are important in health research? So because if you have to communicate, just as an example of that police, regarding that communication also, we need to know regarding the cultural or the shared cultural belief. If we have to, like for let's say chronic disease, so if you want to manage the chronic disease, or you want to have, like, people should take the medicine, because in our locality also we have seen that in spite of availability of medicines, people, there is a perception that hypertension medicine, if the BP is like high, they are feeling dizziness or headache, then only they need to take the blood pressure medicine. Otherwise it is a very hot sort of medicine, they start feeling very hot, so they will say that no madam, we need to take these medicines only when our BP is like, let's say, 160/70. So one student was checking the BP and the patient's BP was 170. So he said that, oh, your BP is very high. So that patient said, no, this is a very normal. I'm not feeling any problem. I'm very much okay. I will not take medicine. I cannot take a medicine because these medicines cause a lot of side effect. Now they are afraid of the side effect, but they will not take the medicine for the hypertension. So to communicate also to the people regarding the disease prevention, especially the non-communicable disease, because follow-up is an issue, you need to understand the cultural domain analysis. And thus such you can say this research work, they support the policy and program design, because they also, if you see the ministry, they make a lot of IC material, behavior change communication strategy. So these individual research help them to make or draft the policy and program design. So how do we study these domains? So there are various ways to study these domains. So free listing is one of the technology where you ask the individual to list all particular items of that domain or elements of that domain. Pile sorting is like when we will see these, but I'm just enumerating. So there is a free listing, then there is a pile sorting. So pile sorting is basically you give these refined lists to the next set of people and you ask them to group based on any similarity which they think of. And then you can see, you can analyze it, the multidimensional scaling. So multidimensional scaling is again, it gives you a visual appearance of those elements. And you can couple these things with either the focus group discussion or the in-depth interview. So we will see how we can do, whether we should do it before the traditional qualitative methods of interview like the free listing and pile sort, like the IDI and the FGD. So again, these free list and pile sorts, it's a kind of interviewing technique. It's a qualitative technique, but if you see, we have learned, or many of you know what is an in-depth interview and what is a focused group discussion. So basically, the in-depth interview and focus group discussion is a kind of interviewing technique. Similarly, these free list and pile sort are also a kind of interviewing technique. And the analysis is also a little different in case of free list and pile sort. We'll see how it is different. So applying these concepts, like we can use these concepts for the disease prevention, like we have just learned regarding the rural area, in the follow-up, in the compliance of the medicine, and in the urban area also, because there is a stigma of insulin in the urban area also. If you see, many people, even in spite of having a very high blood sugar, there are people in my family who are having a, like, let's say, random blood sugar of 250 or 300. But when you will ask them to take insulin, then they are little afraid. No, I don't. My disease is not that much severe. I don't need to take injectable. You just tell me any oral drug. We are not going to take injectable. So that is again, injectable is somehow perceived as a very severe case of a diabetes. So that's how they are not ready to take. So we can use these concepts of these cultural domain analysis in improving the mental health, maternal health status of Bihar also. Like I said, that if you see the literature, they say that in hospital there will be bad spirit. So pregnant women, and this is just one example, that they should avoid going to the hospital. And the cognitive belief may be like mother misunderstand the early pregnancy symptom, because the mothers, when you ask from them, they might say that, I'm not pregnant, or there's a delay in understanding whether there is an early pregnancy or not. So these factors might delay their access to healthcare in spite of the availability. So when do we use this cultural domain analysis in research? Like before or after qualitative studies? Yes, what your answer is? We should use these free list and pile sort or multidimensional scaling before the IDI or FGD, or after the IDI or FGD. Qualitative studies, these are also qualitative technique only. I should not have written the qualitative studies before. Okay, after. So both of you are right. They can be used before or they can be used after. So now think about this situation. If participants say that we don't go to the hospital because the doctors, they don't understand our problems. And that is one of the statement. Here there is a cluster in front of AIMS and many of our PGs go and do the survey there. So they will go to an area which is 10 kilometer away from this place, but they will not come to this hospital. So they say that nobody listens to us and they don't understand our problem. Similarly, participant B says that pregnant women in our village. So now there's a difference. The statement of participant B is regarding all the pregnant women. So he's saying that they don't go for the checkup until 7 months, because for till 7 months it is considered that they should go for checkup after 7 months. So why do people behave this way? So is it an individual decision or it is a shared cultural belief? And how we can study these patterns systematically? So the first is that what all of you have written, like whether we should do it before or after. So you can do it both ways. So we will see how it supplements or how it complements the traditional qualitative research, that is the IDI or FGD. So the traditional qualitative research, basically, that helps us to understand the depth of people and why they say it. But this free list and pile sort, or the cultural and cognitive domain analysis, they kind of, it tells you the breadth. Breadth means like wide. So in this, like less time, you can have a wide view of the people. So this helps to map the shared belief and categorize the knowledge. So it does not replace the qualitative research, rather it complements it. So how it complements it? So first we'll see like how qualitative study, if you, many times it depends, again everything depends on your research question. The need of a particular technique is entirely driven by the research question. But if your research question says that yes, this CDA is needed, then you will do it. So if your research question is like why people delay seeking medical care for tuberculosis. So if you are doing the first approach can be you go and do the in-depth interview of all the people who are suffering from TB or their healthcare provider, or probably you can do interview of 2 3 sort of stakeholder. And approach, the second approach could be a cultural and the cognitive domain analysis. So if you do a traditional qualitative study, so you might get a finding like one person might take the individual. So the individual person might say whatever he will say about himself that my cough, I don't think my cough was that much severe or my situation is that much severe so that I should go to the doctor. Or he can say that according to me, I think it happens only to people who are very thin or people who are very malnourished, or it can happen only to people who are having some sort of addiction. So such a finding you can get. So these limitations are very individual. It is not a shared one. So it is difficult for you to quantify like which is the most common. Because in qualitative, again, you see that we do the content analysis where we show the most common type of the code frequency, which frequency is happening most commonly, but that's not a very quantitative, it's a qualitative thing. But you will see in the anthropac free listing and pile sorting, it's a semi quantitative in nature. That means it's midway between the pure quantitative and pure qualitative. So it's kind of again supplements your qualitative finding. Many times if you see, it is hard for you to convince a person who is a very much true believer of quantitative person. So like so in that case it is like you have learned the all three types, na? Positivist, I'm not going into those terms because those are the qualitative terms. So again, a person who believes that the continuous this quantitative research is the only solution, then it is easy for you to convince through this CDA, because there is, it's a kind of quantitative in nature, and you can present that quantitative finding also. And this free list and pile sort, this will tell you that reasons, it will tell the reasons for not seeking, and it will tell the salience also, like what are the reasons which people find most common and which are the central to this particular research question. So you kind of get the frequency and the salience index of those cultural perceptions and those shared beliefs also. So this, if you see the focus of this, uh, basically the this cultural domain analysis. So, like I said, it covers the breadth of any research. But if you go for the IDI and in-depth interview and the focus group discussion, it kinds of covers the depth. Again, if you go to the data collection method, which is a kind of interview technique, so the kind of technique which we use for the cognitive domain and the cultural domain analysis is the free list pile sort, the multidimensional scaling, and the ranking. And in case of the traditional qualitative, we do the in-depth interview and the focus group discussion. And the outcome is basically here the shared and the structured categories are there. And here again, there is an in-depth insight on the individual reasoning. And it is a quantifiable. Like I said, yes, you can see the clustering, you can see the salience score, you can see the frequency, you can compare also between gender and subgroup analysis also you can do. But in case of traditional qualitative, it is not quantifiable and generally the data is into the text. So basically you say about the theme, the central theme, the theory and so on. But it is not, generally it is not quantifiable. Yes, some quantification you give in the form of the code frequency, but that's it. So generally, when do we use this? So if we can use, like I said, you can use both before and after a qualitative research. So it helps to identify the key topics. If like how if you don't know anything about a topic is very new, and or you need to develop a questionnaire, and even to develop a questionnaire, you don't know anything. So it is entirely exploratory in nature. In that case, you can start with a free list. Free list will tell you a idea regarding the terminology which people use to express a particular concept. So it helps to identify key topics and it helps to draft a question or a questionnaire so that you can do a full in-depth interview and the focus group discussion. So this ensures that whatever you are asking, that is culturally relevant and it prevents any missing important theme in a community. Or you can do after qualitative study also. Like you have got a qualitative finding, but you want to quantify that finding. So you can again go and ask regarding those, and you can complement your the research question which you have already gotten some finding from the qualitative research. For example, we have shared this article, but I'll show this article to you. So this is one of the article which was published in the body image, and here you can see the title of the study. It is the salience of physical appearance characteristics among young women in the Thailand. And if you see the abstract, they have used both the technique. So initially they have started with free listing. So in the abstract, you can see our aim with the present study was to identify key component of physical appearance among young Thai women, free listing and focus group and pile sorting that was used. 120 young women generated 78 unique physical appearance characteristics. So if you see its uses, so how they have done it like in the phase 1, they have if you see the method, so in phase 1 they have done the free listing. We will see this article in detail during the later part of the workshop, but just to introduce the concept like when you should do, so they have started with free listing and they have gotten like 76 list. If you see, this was the list which they got, like physical appearance characteristics, what they consider. And they have taken the interview from the general women who were going to the parlors or the health club. And they were, these characteristics they considered like shapely, skinny, white skin, bright skin, high nose bridge, big eyes, oval face, straight hair and all. And then in the phase 2, what they did with this list, with another set of participants, they have conducted a focus group discussion and the pile sort. So you can see here in the phase 2, they have done this focus. If you can see here, I'm focusing on this part right now, this part. So then they have done this focus group discussion and pile sorting. Because the meaning, we will see the methodology, but when someone, like we have also given the exercise to you people, but we could not ask the specifics of those terms which you have written. What do you mean by the language barrier, or what do you mean by delay, or the lack of time? What do you mean by that? So that meaning in this focus group discussion, basically they did the group discussion to understand the terms, like what they mean by the glowing face. So they said that glowing face is a face without pimple or without any mark, because if someone is saying glowing face, you can't understand. And many of you may be facing this issue with talking to your kids. Like I have a issue because my kids, they have their own terminology and I don't understand what they are talking. So we were also planning that we have to do such type of study in teens also, to understand their taxonomy. What do they say? What do they understand? Because their vocabulary is entirely different from what we talk. And that's how you will see that all those millennial and Gen Z and so many generations are named of that generation is there. So in this, they have tried to, understand the meaning of those, like what do they mean by the broad nose and all those things, right? So we the again remember, in qualitative we have to keep ourselves, bracketing concept. Bracketing is a concept where whenever you are asking, you keep yourself away. That means you don't put your interpretation in when you are taking the interview. So you try to ask the meaning of each word and sentence from the participant. What do they mean by that? So we'll see that. So this is one research where they have done pile sort first, and then afterwards they have done the they have done the free list first, and then they have done the pile sort and the focus group discussion. We'll come back to this article. So I'm going again back to the presentation, that when can we do it? So you can do it before a FGD or IDI, or you can do it afterwards also. And this is just example. If I wish to do something related to the belief regarding the diabetes prevention in a community, I may start with the free listing. What are the ways people prevent diabetes? And then I could go for a pile sort, like how do we group these preventive methods? And then through MDS or through cluster analysis, we may find out which beliefs are more common and interconnected. And then based on those, we can develop a questionnaire and we can ask deeper questions based on the finding. Like if someone is mentioning regarding the herbal tea as a common preventive method for diabetes, or again, like in our community, there's a kind of tree and they remove the bark from that tree, and that's very near to our field practice area, and all the people in that community, they drink that bark of the tree after making it, putting it in hot water, boiling it, and then they drink it, and they say that that cures diabetes. So maybe you can explore further if you know that such thing exists, right? If I'm going in that community and I don't have an idea what are the common methods which they are using. So with free list, I will have a common and few items, and I can explore further using that free list items which I have generated. So am I making sense to all of you up till this point? How this, what is this cultural domain analysis? What is the importance? So Dr. Devjan is asking, yes, definitely. You can use only CDA. Also, there are many, I think we have shared few papers also. There are many manuscripts where they have used only free list and pile sort as a qualitative part. Yes, they have not used the in-depth interview and the idea, this focus group discussion. Because see, whenever you are taking free list, although the type of method which we have done with you people, asking like in a distant manner, that's not advisable. Generally, I should be talking to you people. We can do it over Zoom, like then, because I will further clarify. But there was no scope of clarification from your end. So that's why that is needed. So it's a kind of interview technique only. Whenever they will be telling you free list, you will be inquiring from them and you will write on the back of that paper or wherever you are recording it. So you can use it, this as a part of mixed method study. So CDA provides it as a structured data of shared belief of that diabetes, and then qualitative research or the in-depth interview will give you the in-depth meaning. So if you combine both and kind of like Dr. Devjani is saying, it's a kind of, it will give you the mixed method. That means there are two methods. One is the CDA and another is the quantitative, or here again it is a comprehensive study. So CDA helps to uncover the shared cultural knowledge and cognitive structure that we know. And this qualitative research that explores the in personal meaning or reasoning or that lived experience, because there are various types of qualitative research also. You know, there is a phenomenology, there is a narrative review, there is a grounded theory, there is a qualitative descriptive. So all those depending on our objective, where we want to have a lived experience of individual in the phenomenology or the narratives or just a description. But both these methods together, they provide a richer and insight from the health research. So now let's understand. So now we will start with the commonly used technique. So till now, we were just having the why we should do the cultural domain analysis and how it can complement your the traditional ways of qualitative or even the quantitative one. Now coming to free listing. So what is a free listing? So all of you have done this exercise. Uh, like maybe not fully, but partly. Because we asked a question. And what was the question we asked? Yes, can someone write? Those of you who have responded. Yes, what was the question we asked? All of you have responded. Anything related to barrier related to what? Communication in chronic disease management. Yes. So it was barrier. So we asked you to list the factors which were the barriers in doctor patient communication or the counseling to the chronic diseases. So then what is a free list? So it was an open-ended question. So remember, since this is a kind of anthropology, a technique in the anthropology, it's a kind of you can say it's a kind of interviewing technique. So here also the question will be open-ended. So it starts with the open-ended question. Like we ask, like, what are the barriers in communication in context of chronic disease management? So it's a kind of open-ended question. So in free list also, you have to ask open-ended question. And that open-ended question yields a list of items or a pool. And then using that list, it gives you a comprehensive number of items. Like all of you have listed many factors, and we have now list of, let's say, 25 to 26 list which are there as a barrier for the management of chronic disease. And that is based on the exhaustive recall. What do I mean by exhaustive recall? So you will see that the number of free list, it will be different. So in our case also, like let's say there will be one participant who has given only the 3 or 4 barrier, and there was another participant who has given 8 or 9. So it depends on the familiarity with the subject. Means a person who is every day dealing with such patients, maybe he will give us more list, or person who has got less exposure, he will give less number of list. So this is important that it depends on the cognitive level of the person and the familiarity with the topic. You might get a different number of lists from each other person. But of course, after each of this, it will give you an exhaustive recall. And then, but remember, whenever you take this, it's better to make that person sit in front of you and do the traditional way, because when these days with the invent of AI, you will see whenever you ask a question, even from the UG students, all the time they will just put that question in the chat GPT or any other AI and they will give the answer. So uh, because then it will not be a recall of that person. Are you getting what I'm trying to say? If you ask this question and if the person sees in Google, so that's the Google recall. That's not the recall of you as a person. So that's how now it is very much important these days to, I mean, interview a person without phone or without having any such thing. Then only you can come to know regarding the exhaust of that collective exhaust or the recall of that person. The next thing is like one. We always say it has got one level of contrast. What do I mean by one level of contrast? So, one level of contrast means the participant here, they are saying, like, if I ask from you regarding the communication barrier, all the items or the list that is related to the communication barrier. So, that's why we say the one level of contrast. What is not the one level of contrast? That means if I ask some broad categories, then it is not a, it's a kind of like a, even if my question would have been very broad, then you would have given a mixed sort of response. So I could have clubbed these to make a subcategory. So that's a kind of example of a subtypes or example of a small category. So then it is not a single level of contrast. If I ask to name fruits, then all of you have written the name of fruits only. So the my question should be clear so that I should have all the responses which are comparable to each other. That's how I mean by the single level of contrast. It should not be a list or as a group, it should not be there. So why we should stick to the single level? Because if we get the list from the participant, they should be comparable, because when you calculate the salience index and ranking, we can only rank the list which are comparable with each other. And it is easier to calculate the frequency, rank, and salience index, and it gives you a clean input for the pile sorting. Because again, what is pile sorting? So you give the list, you refine these lists, and you give the same list to the next group of subject and ask them to, although in your case we have to do this with the same set of people, like we have asked the list and we have given the pile sort, asked them to do the pile sorting from the same group. You can do this also, but generally the two set, classically the two sets should be different. The list, the people who get generate the list and people who do the pile sorting. So it prevents mixing of terminology, because if the levels, if the list are belonging to the same level, then there's no mixing of the meaning or the terminology. So what are the uses? So you can have, like, traditionally it was invented for the social network relationship. We will share that book, and if you go through that book, so initially that says that during 1870, all those kinship relationship like brother, sister, nephews, grandparents, father, all those relationships, the terminology they have derived through this cultural domain analysis, which was the free list and pile sort. So that social network and the relationship and all, who is near and who is distant, that they have done through the CDA. And again, it has got use in the environment also, because many environment people, they are also doing research, and in health also. We have shared one article with you where the author has tried to know the terms of the various disease, like ADHD. How do the people define ADHD? So they have interviewed a pediatrician as well as the parents and the teachers to know the common terminology which they use for ADHD, some common terminology for Alzheimer's. So then also you can do the cultural domain analysis, the free listing. Now, there are various types of free listing. So what are these types? So there can be free listing with single question, like we did. We only gave you one question and you have provided us with a list. So there can be free list with multiple related questions. We'll see this with each one by one. And there can be free list with the contrasting questions. Means, and then there can be successive free list. So these are the types of interview again. These are the types of interview technique, and you can frame your questions like this. For example, like single question is we all know. But if I have to use multiple related question, how will I do that? So Weller, who has done a lot of work in this cultural domain analysis, he did a study in 1986, and his domain was he wanted to understand the characteristics which influence the choice of infant feeding methods, breastfeeding versus bottle feeding. So what he did, he uh, asked from the women 18 free listing questions. So how those questions was there? So those questions was like on the various perspective, like reasons, advantages, disadvantages. And those questions were like, these are the questions. So they are the 9 questions. So initially, like here he's asking, what are your reasons for wanting to breastfeed? Why do some people breastfeed? So 9 questions were related to the breastfeeding. And then again, the 9 questions were related to the bottle feed. So he has replaced each of these, like instead of here breastfeeding, next 9 questions were regarding the bottle feed. Here again, the bottle feed. And then he will ask, why did you decide not to breastfeed? What are the disadvantages of bottle feeding? What do you like about the bottle feeding? So one set of question he asked regarding the breastfeeding, and next 9 he asked regarding the bottle feeding. So this is known regarding the multiple questions. Now, second is the free listing with contrasting questions. So, Young, he has done a study in 1980 regarding the healthcare seeking choices. And instead of asking, like, why do you go to a doctor? He asked, why do you go to a doctor and not a pharmacist? So, if you see the question, he has framed his question like this. Instead of asking, he asked, why would you go to a doctor? And the second part was, not a pharmacist. Or, when would you go to a pharmacist and not a doctor? So, this is like free listing with a contrasting question. Okay. So, free listing can be from a single question. Free listing can be with a multiple questions, like the example of Weller, where he asked 18 questions, 9 for the breastfeeding and 9 for the bottle feeding. And then there can be free listing with the contrasting questions, like you have seen. So he got a very clear reasons and sharper distinctions between the free list item of the bottle feeding and free list item for the breastfeeding. Then there is another type, which is the successive free listing. What is successive free listing? So successive free listing is the informant generate one free list, and then from each item of that free list, he generates another second free list. So this was done, and this creates a kind of causal association, like related domains. So, for example, again, Weller has done this study in 1987. So, he has done this study on teenage students, and he asked, he generated the free list with this question. Let's say, like, what things do teenagers do that make parents or adults angry? So, this free list he generated. Then again, he linked this follow-up questions with that free list item, like when do you do this, what do your parent do, right? So then he got another domain which was like adult responses. When the teen were misbehaving, what do the adult do? So he got like connected one. So that was kind of linked. The first free list became the inquiry part for the second free list. So this is again one way. So again, if you wish to do a free list, you can do it with a single question. You can do it with a multiple question. You can do it with the contrasting question, like why you go to a doctor and not to a pharmacist, or you can do it with a like successive free list, where one set of free list will generate the question for the second free list, like Weller did in 1986 7, where he when he did this teenage generated the teenage free list, and from that free list he asked, like, when they do such activity, how do the parents respond? So he has connected the kind of child's behavior and the parent response. So kind of causal. So there are some probing technique for this free list. Like whenever I give something to list, I should understand like what probe should I use. So there can be non-specific probes, like I may ask the person to recall more if the list is less, or I may recap or the revise or the repeat the same thing and ask for more list, or I may ask like any similar or related items related to the list which they have said. So these probing technique helps to generate more list if the number of list is small, or if they are not coming up with the list. So how to record the response in the free list? So generally, uh, it can be two ways. If the participant is literate, you can give them and they might write it. And if they are not literate, you may ask them to repeat and you can write it down on the piece of paper. But again, you should write responses exactly how they have said. And you should clarify, like I was saying, the meaning. What do you mean by this? What do you mean by this? Like for one example, which we found that in the same book, that in the same study by Weller, he has written that some chose breastfeeding because it was convenient. So what was the meaning of convenient? So meaning of convenient for those group wise was like there was no bottle cleaning was not required. So that was the term convenience said in that particular study. But another group, bottle feeding, they chose bottle feeding because it was convenient. So the meaning of convenient for the ladies who were preferring bottle feeding was because they don't have to expose their breast in the open public, or when they were using the transport or in any family gathering. So that was the convenience for them. So the term is convenient in both the case. But what do they mean by convenience? That you have to explore further. So that's how the role of probing will come. Am I making sense to all of you up till this point? Okay. Thank you, Debjani and Priyanka. Now coming to sample size. So, because if you wish to do a study using the CDA, what should be the sample size? Any guesses? What should be the sample size for the free list? Thank you, Antonio. Yeah, any random number. You all have done the qualitative. Okay, so Dr. Ravi has written 20, 10 to 15 till saturation minimum. So yes, if you go by the book which I have just shared the reference, he says that 20 is, although we say that it depends on the saturation and all, but he says like at least it should be minimum of 20 should be there to generate the free list, assuming that each participant will give at least 10 to 12 items. That's the rider attached to it. If the number of free list item generation is less than that, then you may need to increase the number of participants. Yes, snowball sample you can do that again in a qualitative method. Generally, we go for a snowball sample because it's a kind of purposive sampling, and you want people who will generate more free list or who have got that much familiarity with the topic. So I think we have done this. Ask participant. This is just the method. Yes. So now coming to, so you have like got these You ask the question like list the language related barriers in the patient provider communication, and you people have done it. Like I will just take the example, whatever you have done. So let's say this was like piece of paper. We have just refined it, and for demonstration, we have written it. So all those responses you have written, like first person has written, and we have not named it here. We have just given like code participant 1, 2, 3, and 4. So, like doctor speaks too fast, or patient does not understand, uses too many medical terms that patient finds difficult, or patient hesitates to ask doctor for clarification. The fifth number of participants, he is saying like doctor assume patient understand, does not explain, patient with low literacy cannot read. So many times you will see that this is a very long sentence, and such long sentence you will have to refine because it's a raw data. Again, here also in participant 4, if you see, he's saying like accent of doctor makes it hard for the patient to follow, or healthcare worker from different region use unfamiliar term. In case of participant 2 also you will see instructions given verbally, but patient prefer written guideline. So if you see this, you will see that there are terms which are like duplication. If I say like a patient does not understand, or here the doctor assumes patient understand, so you can make these two and make one like there is a maybe the communication or there is a understanding issue, or here also here written like medical terms are too complex for the patients, or if I say uses too medical, these two uses too many medical terms that patient finds difficult, these two. If you see these two, so I will refine these. Maybe I can write like use of complex terminology by doctors. And I'll replace these two with the same one, that particular one item or that particular sentence. So many times whenever you ask from the person, he will kind of give you a crude list. So now you have to refine that list, and that process is known as the harmonization of the listing. So, like this was the raw response. Doctor speaks too fast, patient does not understand, uses too many medical terms, patient hesitant, no interpreter available in the hospital. If you see instructions given verbally, but patient prefer written guidance. So with the different colors we have written it, medical terms that are too complex. The same hand written notes we have written like here in the Excel. Accent of doctor makes it hard. So now what is the next step? This is the first step. So next step is the cleaning and harmonization process. So what is that basically? So here what I will do, I will remove the redundant words. That means any words or any statement that is very much similar, I will merge the similar statement for clarity, and I will use some standardized terminology, and I will retain the participants term. That is very important because I cannot replace the whole uh, sentence. I have to ensure that there should not be a content loss when I was making the response. So I will show you the Excel sheet how we have done that. Your responses. So this is the raw data. So you can see we have just written here with the name like Ashwati, Antonio, Devjani, Manisha, Hema, Naveen, Paramita, Pradeep, Shweta, Saraswati, Viber, Rizwana, Rini, Krishnadev, Ravi. So we have taken these many responses, and if you see, we have written the raw responses. Like Ashwati has written use of medical language by doctor, lack of familiarity with the regional language, difference in cultural context, lack of time, patient overload. So these first six list it was given by Ashwati. Then Antonio has given like cultural difference, mistrust of the researcher, reluctance to answer at home, fear of being judged, fear of being exposed, reluctance to interrupt work. Again, Devjani has also given like awkwardness, fear of retaliation, persistent questioning, further support information, lack of privacy, prolonged counseling. Manisha, if you see, she has given again increased workload, inadequate training, motivation lack, language barrier, low literacy. So, like language barrier, if I would have been, I may be asking like what she meant by the language barrier, whether it is the barrier related to accent or barrier related to the use of medical term or barrier related to not knowing the local language or what. So if the participant is there in front of you, you can further clarify what she meant or what he meant by the language barrier. So these are the terms. So you can see there, these are the various response. Again, Paramita has written noise at the OPD. The low education, long queue. Pradeep has written intelligence, education, time. Again, he has written time. So probably I am guessing that he must be uh, trying to say like less of time or lack of time. Intelligence level, again, intelligence level of whom? Doctor or patient? That needs to be clarified. And then the language. So probably if I would, that's why I said that you should clarify. If Pradeep is saying language, then language is little broad. So probably if you will interview, you will further clarify what he meant by language. So Shweta again written low health literacy, Saraswati, difficulty explaining scientific terms, language barrier, lack of time. Fiber has written socioeconomic constraints. So again, I would ask like what he meant by socioeconomic. Poor follow-up. So each term, like you could clarify what they meant when they are writing. If something is not clear, if it is clear, that is okay. Hearing ability, ignorance. Now again, ignorance, I will ask. Ignorance by the doctor or what? Like poor intelligence, poor IQ, she's writing. So of course it will be poor IQ of patients. But we have seen poor IQ of many doctors. I mean, not doctors, poor, not, you can say attitude. Like they don't want to talk. Here, if you say in Bihar, they will say that if you talk more, they will think that you don't know or you are not a good doctor. So they say that we talk less or we talk only for a few seconds because we want to show that we are very busy and very, very, you can say, experienced doctor, and we have so many patients that we don't have time for every patient that much. So just because they want to show that they are very big doctor, they talk less. So that's the kind of perception here. If you talk to any private practitioner here, so one time I was asking like, sir, you have not even seen towards the patient, towards the face. So he said, no, madam, if you talk to them more na, they will not respect you. So if you want to gain respect, you should not either talk or you should talk very less. So that's again, if I am asking from him, he might give some other insight. So that again, it's a different scenario. That's why I said it's a cultural domain. So that domain will be different in different states, or in one state also it will vary locality wise, urban, rural, or many other area. But it's very interesting if you talk na, and if you do some studies na, you will find it very interesting when you come to know regarding their perception, their taxonomy, the kind of terms, the kind of perception which they have related to any phenomena or any domain, you can say. So this was the raw data, right? I should not deviate from the main topic. So now coming to this is the harmonized process. So how we have done it? What we did, we have written all the list here, raw one, which like with the example of one Ashwati, I think Ashwati and Antonio. These two we have taken for refine just to show. So we have written all the raw data of Ashwati here. use of medical language by doctors, lack of familiarity with the regional language, all those. And then what I have done, we have just assumed. Uh, Ideally, it should be done after you get the clarification. So that clarification should also be written. But here I am writing like use of technical or medical jargon. Again, lack of familiarity with regional language. I have written the language mismatch with patients. And again, here, like different in cultural context, I have written like cultural mismatch or insensitivity. Lack of time, again, that is we can combine it with the patient overload, because the time is maybe many times due to the patient overload or multitasking, a lot of other work, like maybe one person is there. Like today also a few people have written that they been called for the administrative meetings. So if the doctor is there and some person calls him for the administrative meeting in the morning hours, then of course he will not have that much time. So it can be due to the patient overload or it can be due to the multitasking. So that you need to ask what he meant by lack of time. So that we have defined this, the first code of Ashwati. So the refined list of Ashwati is like, I've used use of medical jargon, language mismatch between patients, cultural mismatch or insensitivity, time constraint due to patient load. I don't know, but I've just written it. For example, and this is the repetition again, same. So both these two I have converted to the time constraint due to patient load, inadequate communication training, and digital, like she has written here, lack of training in communication and the lack of familiarity with the technology. So I will ask, but I'm just writing here by myself, assuming that digital skill gap, probably. So this was regarding the Ashwati. If you see the Antonio's this thing, then he has written like cultural difference. So again, I have kept it like cultural mismatch between the provider and patient, mistrust of researcher, lack of trust. That's, I think he has given it accurately. Reluctance to answer at home. So discomfort discussing health issues in certain setting. Patient fear of being judged. So patient fear of being judged. Fear of being exposed. Again, privacy concern or the fear of stigma, and reluctance to interrupt work or time constraint due to work commitments. So I have just refined it. We have just refined it, and then this is how the next sheet is of refined data. So you can see here, uh, this is the refined code of each one of you. And again, like I said, this we assumed, but of course, you will do it after asking the meaning from the individual participant. We could not do it because it was not the way it should have been done, like face to face, or probably I should have given you the time to clarify, should have asked the questions, but that process was missing. But I guess you will understand how it should be done. So this was regarding the various, and here you can see, like which we have colored it with red, like low health literacy, low cognitive ability, low literacy level. So I will merge these to one by replace this all by one. Educational status, low health literacy, even the time constraint, you will see the time constraint for effective communication, time constraint. So, in spite of harmonizing, also you will see that you will receive some codes which are very similar here. Time constraint and time constraint for communication. Okay. Am I making sense up till this point? Okay. So I can अभी देना great. So do you need a break of, let's say, 5 minutes? I think, okay. Priyanka said no. Okay. Okay. Then how is this different from coding? It's a kind of, okay. Okay. Antonio is saying yes. So that's a problem. Okay. I will not move ahead. We can stop for 5 minutes here. Those of you who wants to go for some natural break or have water or something like that, you can have. Devjani has asked one question. How this is different from coding? See, in coding, generally, if you can recall the various types of coding, there is a coding where you make your interpretation also, because there in the qualitative interview you don't have time for each and every sentence to clarify. Definitely you clarify, but that meaning you give, many meaning you interpret. Like there is a, if you see there is a in vivo code, so you take that sentence, so probably you can say it's a kind of in vivo code. If you want to make similarity between the coding process and giving the name in free listing. So maybe if you can recall the NVivo code, what was the NVivo code? We used to pick few phrase or words from that sentence and we used to replace that. But in the NVivo code, as the name suggests, the inherent meaning and the terms and the words was preserved. Here also we are doing the same thing. But if you can remember the other type of code, like there was a lumper code where the whole paragraph was replaced by one word, or there was an emotional code when we used to give some emotional word to that, or there was some descriptive code when we used to replace the 4 5 sentence with kind of few words or few phrases. So in the coding process, you attach meaning to some extent, your own meaning also. Why? Because remember, we used to say that the story is co-constructed by the researcher and by the participant. So there, the story is co-constructed, but in case of free list, like we said, it's more of a semi-quantitative. It's not that much qualitative in nature that you will attach your meaning. Here we are not attaching any meaning. We are just refining and trying to be as adherent to the meaning which the participant has said. So by refining means just some language issue or some uniformity. Like if someone is saying low literacy level, and then if someone is saying like low cognitive ability, or if you say there is another term, I'll just show with this red one. Low health literacy. So maybe this low health literacy status, I am replacing these terms with one term because they are almost same. So that's why it is very much different from the coding process. In the coding, we don't do this work like refining and all. There, generally, our aim is to merge them and make them category. And there are many codes. So if you see the analysis, those individual codes that even don't come up. Let's say if you generated 50 to 60 codes, that 60 codes generally doesn't come up in the analysis. I mean that they remain in the background, and you generally talk at the level of category and then at the level of theme. But here, in case of a free list, you try to be as adherent to the words which participants have said. Of course, you will ask because you want it. We said that it should be at the same level. So that's why they should be comparable. So you will attach some refinement, but the meaning will be very much preserved. First difference is this. But again, if you want to say that yes, it is to some extent similar, then you can say that NVivo code is very much similar to this process of attaching meaning or some giving phrase to these free list item, right? And again, the number. In case of a coding, that full paragraph or text you convert it to code. Here, it is the same list which you will preserve. If Ashwati has said 6, I will retain that 6 number. If Devjani has said 12, I will retain that 12 number, right? But in case of a coding process, if one person, you can get, let's say 20 codes, and from one person you may not get, let's say, even 2 to 3 code, right? So it depends how rich that interview is, but here you will preserve. So did you get the difference between the coding and the process of free listing refinement? So Devjani, harmonization, yes. Basically, harmonization, partly it is done with the participant. Of course, this much extensive process you cannot do with the participant in front of participant. And harmonization is done when you have got the list from all the participant. You cannot do it like individually. So initially, when you are asking, you refine, you write the meaning, whatever they are saying. You can record it also. Like if it is difficult for you to write, you can you can talk and you can record the meaning so that you can convert it to the transcript also. But then and there, it's better to ask from them what do they mean by some specific term. And then the harmonization is done. So it is after that. I hope I'm making sense to you, Devjani. So now we may go to next process, that is assigning rank-wise list. So next sheet we will share these list with you so that it will become for you. So this you can see here. Now I have done when I have refined these I have done the harmonization. I will now do this ranking. Ranking means I will write first what Ashwati has written. So if you see the raw data list, she has written use of medical language by doctors first, then number 2, number 3. So this maintenance of recall is important. Whatever the participant has said on the first number, that first number will be given by me. So I have given rank of 1 to this, 2 to this, 3 to culture, 4 to this time constraint in consultation, 5 to high patient load, and 6 to lack of provider communication. Similarly, Antonio, if you see, we have given the first rank to this culture and religious mismatch, mistrust or lack of confidence in healthcare provider, 3 to the emotional discomfort or psychological distress, 4 to privacy concern during consultation, and 5th to high patient overload or overcrowded setting. Similarly, Devjani, we have given a rank like emotional discomfort. The first one, the second is time constraint, the third is poor follow-up. So if you see the time constraint here also, this Ashwati has given this time constraint at 4. The Antonio has not mentioned the time constraint, but again Devjani has mentioned this time constraint on 2. And if you see Manisha, she has written as time constraint of 1. So this is the difference in ranking. The time constraint has been given by 3 people. I am just giving example of 4 for demonstration. But one person has not mentioned it in the list, which is Antonio, and 3 people have mentioned this in the list, but with a different ranking. With the Manisha ranking it on the first, and Devjani ranking it on the second, and Ashwati ranking it at the 4. So this way, Ashwati has written it at 4. So this is the ranking, and this we see you get it in the form of a average rank in the and this. So now what I will do, this data, it will be arranged. So I will show you how to enter the data now in the TXT. So this is the Excel. You generally we don't do it in Excel, but for harmonization and data refinement, if you use Excel, that is better, because Anthropac the interface is a little difficult for refinement of data. So if you do refinement here and then,
Excuse me, ma'am.
yes,
I
Devjani.
think so. There are 2 questions in the chat box, one by me and another by someone colleague.
Okay.
Same thing. We need to deal with this before we go to the next
So
explanation.
Ashwati has asked, can we choose to use a refined term after clarification with the? Of course, that will be
No,
done. Only after clarification.
No,
Acha.
the question is, do we ask the participants to list them according to what they think is most important to list
No, no,
important?
no, 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 no. You don't ask this.
This is
You,
this is unstated. They do it on their own.
yeah, yeah, you just ask them like they should list. They will first, whatever they first, it is automatically, because if you ask categorically that they should list according to importance, then you are kind of biasing him. So it's a kind of understood thing that if I ask this question, name fruit, name five fruits, or what fruit you have written today. So whatever first you have written, that was the predominant this thing in your domain. Or what item do you have in your refrigerator? So for calculation, it is considered that whatever you have answered first, you have ranked that as a first thing. That is understood. You don't ask this question like they should place from like the most important to less. No, then it is not natural. Then you are biasing that person. Then he will have to think in in his or her mind, like, you are adding one more step. Then I'll have to think, oh, because till now I have not thought of. Like, see, there are many questions which you have not thought of. If I ask you, list five color which you like the most. If I ask this question, what will be your answer? This question to you, Devjani. If I ask this question, Devjani, list five important colors for you.
Uh, it depends upon the framing of the question. If the question
No,
is
simple. This
favorite
question I'm
colors,
asking.
then automatically I'll go from best to worst.
Yeah,
But
because now I will not ask. Like, you might, if you ask from this question from me, I will say white, I'll say black, and then red. So whatever I am answering spontaneously, that means in my cognitive domain, the first answer has got a most important place. Remember? Ah,
so we are trying to basically ascertain what the subconscious is saying
yes,
without a direct question.
yes.
Thank you.
You are welcome. Ashwati, can you place that? How it is different from coding harmonization?
The same question, ma'am, you have answered it.
Okay. Okay. So now we will go to the txt file. So how to enter the data? We'll see. So what I'll do, I'll open the txt file, because for analysis, although we have shared, but how to enter the data? So let's say you can go and just, I will open any, do the right click and click on this new, and there is a txt document. So this is like, let's say, for practice, and I have opened it. So you open the txt file, although we have given you the template, so you can just replace the content. Because in this, for analysis, it's very important that you should enter the data very accurately. Because this txt file, if you see, so you should always start with title. So I'll just show, for example, so let's say this was the, so you can see here, whenever we start any, this was the previous template. I'll again show. Whenever you start something, it should be with a star. So like title, and then I'll write, then respondent data, and then I'll write the respondent, and then this is the free list. And free list, you can write it with name also, like respondent uh, P1, P2, P3, something like that, participant 1 or participant 2. So how I will do? Just a sec. I will hide this, and this is the txt. So first I will do the star, this put a star, and I will write the title. And then I will write title, let's say, communication barrier. And then again, when I have to start the new thing, like let's say respondent, again I'll put a star and I will write respondent detail. Respondent detail. And then I'll write, let's say, participant. If I have to write like P1, P2, I will write P1 and ID, because again, this is with the ID. So what ID I am giving? And if you wish to write like age and all, then put this cursor of tab, put tab and write age, again tab, and write probably gender, if you have to write gender also. Although we have not asked this from all of you, but I'm assuming. So in ID, you can write here, let's say P1. So this is where you can write P1, and then again go with tab age, let's say 24. Again go with tab and let's say it is female. Again press enter, and this is how you can enter the data. So which you can see here. We have written the data, this whatever you people have. So free list. So this was the free list. You can see the title with a star, the respondent data, ID, gender, and free list. So here when you start the free list, you have to write like this. Free lists. You can see here star and free lists. If you write free list, if you don't write S, then also there can be like see. So whenever you have got any problem in importing the sheet, just see the reference sheet, how it has been entered. So then you can enter like respondent 1, and let's see, respondent 1 was Ashwathi. So if you see, I will write all the items the way she has written. So use of complex medical jargon, language barrier, all these 6 I have written. So how I have done? That Excel sheet which you, just a sec. So this list which I prepared rank wise, what you can do, you can just copy this, not the name, only from the list. You can do the Control C. You can come to that txt file. And I'll paste this in the practice, this thing. So what I'll do, let's say participant 1. So I'll write star free lists. Okay. Then I'll press here P1, and you should write whatever you have written here. That means the ID of this and this should be same. It is not like here you write P1 and here you write name. No. And then you press enter and then Control V, copy paste. So you can, this is how you can copy paste. Then I will again put go here, enter, participant 2, again enter. I will go back to the Excel sheet. I will copy this Antonio's list. Control C, window tab. By pressing window tab, you can keep on moving from TXT to Excel. And then I'll press Control V. So this is how you can copy paste the list which you have refined on the Excel to the TXT file. Am I making sense to all of you up till this point? Let me see the chat.
Responded one flag on previous one considered.
Okay. Need not to add ID. Okay, where in here free list? No, here no need to add the ID, because ID you have written and this P1 is the ID only. Let me check, otherwise free list. And always refer to the previous sheet. If you like, many times we do make error, so I always go and refer to the sheet which I could import and which I could do the analysis. So if I see this participant 1, 2 and 3, and if I come down, no, you don't need to put ID here. You can see here. It's only the star free lists. And then I started with the respondent P1 and P2, etc. ID is not needed. Okay.
The respondent word नहीं लिखा है अपने लिखते समय सिर्फ P1 P2 लिख दिया है.
Okay. So yes, Dr. Shamshad is right. He is saying that I have not written respondent. Let me check. So since you have written respondent data, so I need to write respondent. So in practice, here, yeah, you need to write, because here I have written star respondent detail. So I need to put this,
Detail नहीं.
sorry, respondent ID. I need to put here respondent word, otherwise it will not take. So what I do generally, I go with the whatever the initial, the previous data template is there, I replace that with the new one. So that way all that stake at the error, generally you try avoiding that error. You can copy paste that respondent. So yes, respondent P1 and P2 like this. So whatever you have written here, you have to write the same thing here also. Respondent P1. So this is how you do it. Now, here data is here. It's not ID, it's
ID.
data. कोई बात नहीं, उससे कुछ नहीं होता. So now coming to the analysis part. So analysis, let me see if something is there. This we have talked. Harmonization we have talked. So now I'll show that in Anthropack. The system slow, it is getting slow.
जीरो आ रहा है. अच्छा ऑफ नहीं होगा ऑन लिखेंगे.
So I'll go to the now Anthropack. We'll go to the analysis. So for that, let me close the this practice one, or I will import the same one. So go to here and type Anthropack. That come both free list and pile sort. So you can see, if you type Anthro, you can see here I have got both these Visual Anthropack free list and pile sort app. I think we have sent the brief recording for all of you to see how you can download the free list and pile sort Anthropack version. All of you have done it? Okay. So I will again go here. I forgot to open that, so I'll. I'll open this free list. I'll click this. So when you open this Visual Anthropack free list, the interface will be like this. So it has got file, edit, items, respondent. You just click this file and you click this open. When you click this open, then in the free list exercise, this is my file. So I will show, because I will show this is of 2811 and the last file was till 1026. So see the time, because if there are many txt file, there will be problem. So I have to extract, open this. So I'll click open. And you can see here, the moment you open this file, all the analysis will be done. So before I explain this to here in this interface, I would explain the concepts first, and then I'll come back to this interface. So we have done up till this point, retain, free list. We have avoided redundancy, shortened the sentences. Now we basically calculate three things. We see the frequency. That means, what is a frequency? That means a particular item. How many participants have listed that particular item? Like, remember, I was talking about that lack of time. So lack of time was mentioned out of 4, 3 people, but Antonio did not mention that. So frequency is out of total participants, how many of them have mentioned a particular item. That is frequency. Then rank order is the position of each item in the participant list. And then on the basis of both these rank and frequency, the salience index is calculated. So this salience or the Smith index, that is automatically calculated in the Anthropac. But you need to understand the background, how it is calculated. And for that, we need to spare few minutes here, how it is calculated. So this is the interface. You can see the data which we have tried to show you the same analysis through Excel. Although you don't need to do it, but you need to understand it. That's why if you see these background calculations, it will be helpful for you when you write the analysis or when you write the interpretation, or even the understand your finding, because understanding the output of Anthropac is important. And for that, we need to spare few minutes here. So you can see here, let's say these are the 14 free list item, right? These are the 14 free list item which I have created. And P1 is participant 1, P2 is participant 2, participant 3 and participant 4. So if I say fast speech, so fast speech is not mentioned by participant 1, 2 and 3, but it is mentioned by participant 4 and participant 5. But at which level? At, you can say, fast speech, the ranking is 2 at the level of participant 4 and ranking is 3 at the level of participant 5. Similarly, complex medical term. If you see complex medical term, that's been mentioned by participant 1, 2 and 3, but not by 3 and 4 and 5. And the rank is like the first person has mentioned it on the first rank, the second on the third and third on the fourth. So this is the data. You don't need to enter the data like this, but how the analysis is done, that we are showing. So this is one thing. Now we need to calculate three things: the frequency, average rank and salience score. So how frequency is calculated? So frequency is like out of 5, how many have mentioned this fast speech in their free list. So frequency will be what? 2. What will be the number here? Yes, all of you type. What will be the frequency here? Although in Excel you can do this, what will be the number here? Okay, Devjani has written 2. What is the number here? Next, complex medical term. Only for example, out of 5 I am asking. 3, right? What is the number in case of patient hesitate to ask questions? This one, 0. Yes, true. Local dialect versus English. What is the frequency? 2. Right? No interpreter. What is the frequency? 2. Incomplete family translation.
पीसी में होगा तो नहीं भाई तभी लिस्ट में है
Yes, 1. This is only for example. Like 0, if it is in the list, someone must have mentioned it. I'm talking about this. I'm talking about this patient hesitant to ask question. This is 0 only because example first 5 did not mention it. But it is in the list. Someone must have mentioned it. Okay. Yes, right. Complex medical terminology 1. Unclear prescription 1. Accent difficulty 2. Then 1. Then again 2. And then 3. That means number of people who have mentioned, that is frequency. So this is how this is counted. In the Excel, if you do the count and only give the range, it counts. So you can see the next, all the number which you have written like 2, 3, 0, 2, 2. This is here. Okay. Now coming to the average rank. How the average rank is calculated? So average rank is, let's say it is calculated again by item wise, the free list item wise. So let's say fast speech. So this participant 4 has given the 2 rank and participant 5 has given the 3 rank. So what will be the average? It will be 3 plus 2 divided by 2. So it will be 2.5. So average rank is calculated the addition of total rank divided by the number of people who have said it. So the formula in the Excel is average from B2 to F2. That's the rank which is calculated. And this is the rank. Otherwise, kaise? If you can do the mathematical calculation, if I ask this, you can all do it manually also. Just for example, do for this complex medical term. What is the average rank? So it will be 4 plus 3 plus 1. So total 8 by 3. What will be the value of 8 by 3? So Rini is asking if software hangs after many data entered into the same template. Make a copy of it. If you are asking this question, that means maybe you have faced this issue. Is it true, Rini? You can make a copy of it or you can make an entirely new TXT and just see the previous data entry and you can do it. Okay. Yes, Ravi has rightly said 8 by 3 is 2.7. So that's the average rank. Although again, I say, I'm saying it repeatedly that you don't need to do this. If you open the data in Visual Anthropath, it gives you all the calculation. But what is happening at the background, for that, we are showing this Excel, how the Anthropath calculates it. Am I making sense to all of you? Please don't think that you have to enter the data in Excel. For harmonization, you can do that activity. But for analysis, there's no need. Analysis can be done. And for that, we are learning this Visual Anthropath, right? Now coming to the salience score. So what is a salience score? Basically, salience score is taking when it takes the frequency and average rank both into the consideration, it calculates the salience score or the Smith index. Index, many times you will see. So how it is calculated? So basically for each participant, it calculates how many items are there in the list. This is the list of the total list each participant has given. And then the formula for this is, it's a little tricky, but just for demonstration, I am showing it for the complex medical term. So complex medical term, it's like 1, 3, and 4. If I'm taking this to another sheet here. So 1, 3, and 4 was the rank given by for this complex medical term 1, 3, and 4. And the total number of items listed by these participants are 4, 3, 5, 6, and 2. So the formula of salience index is n minus ri plus 1. So what is n? N is the total number of item listed by the participant, which is 4. And this ri is the rank of that item by the participant. So it is minus 1 and plus 1 here divided by 4. So this is the individual salience score. Similarly, for participant 2, it is 0.25 and participant 3, it is 0.5. So the average salience will be your 1. You make it like total and then divide it by the number of participants. So this is the salience score of this item, which is the complex medical term. But again, you don't need to calculate it. Salience score in order of importance, the visual anthropac calculates it and it gives you. Right. Now we will go to the interpretation. So we have seen, if you see this visual anthropac, I've imported the data. Now see how the data looks. So if you see the first one, this is your text data. So this was the data, the TXT file, the respondent ID, like gender, 2 things are there. And one very important thing which I want to clear. If you see the free list, it is the P1, P2, the way we have written in the TXT, all the 20, okay, 16, we have taken 16. Then this is the data, and this is the individual attribute matrix. That means item matrix. So item matrix means it has taken all the items which we have listed and all are enabled. So their total are 20 items and all items are included in the analysis. Now this is your respondent matrix. So respondent matrix you can see here. Participant 1 was female, yes. And then again participant 2 was male, yes. And female, yes. So this is respondent matrix. This is the frequency of the item. And the frequency of item, the way we have shown, like this is the frequency percentage. This is the average rank. This is the frequency percentage. That means 68.8% of the people have said this as a list. This is the average rank which we have just seen. And this is the salience. So salience means this is the most important shared culture, shared domain. This was the most important, the language barrier. Then low health literacy, it was next, followed by this. Again, if you see, this is not the like order, you can arrange it, but it is again 409 here. So it is higher than this too. So this is not in the order. How come this has come in like time constraint? This has like, I thought maybe it is arranged in order of decreasing this thing. Okay, so if I do the right click, sort descending. So now you need to sort it in the descending order. So now it is in the descending order. 0.24 followed by 0.409, then 0.385. This is your item-wise frequency.
I think so. It will be organized one of the columns. Frequency column, I think so, has become altered. If you put the salience column in descending, then frequency column, I think so, it's not descending anymore. So it will be according to any one of the columns. Whichever,
Yeah, actually salience, why? Because salience, it depends which is important for you. So you can arrange it likewise. But salience generally, when you have to take the items, we take it on the basis of the salience index, because that has got the components, both the average rank and the frequency. So salience is the most important. So that's why I have arranged it. Maybe you can do it other way around also. But generally, you see that we take the items which are like most upper 10 or something like that. If there is a constraint of time and you want to do the focus group discussion and you cannot include every item, then what you can do, out of these 20, you can take the upper 10, which are having the highest salient index. So that's why probably I have arranged it in the descending order. But again, it is not important, not a mandatory criteria. You can keep it like descending frequency or rank, whatever you seem that that is important for you. So this was, and this is like respondent. If you see the length of the list, this is again, you see that respondent, now it is again giving you according to the frequency. So 60, 57, 55, 52. So that's why you will see the participant here is not like P1, P2, P3. It's like this. So if you wish this to be like P1, P2, P3, you can write it. But generally in the result, we give this one. The item and the frequency and average rank and the salience. So just we will go back to that article which I was showing you, that body image. And I will show you how they have physical appearance. So if you see the result, they have written like a total of 120 young adults took part. And you may give the minimum and maximum number of items also. So they have given like 78 unique physical appearance characteristics. And the average number was 48. So they have given the average number. The minimum number of characteristics was 32 and the maximum number was 77. So you can also give this range from your file. What was the minimum number of response, what was the maximum, and what was the average. For this, you can do it with the Excel. And there were 48 characteristics that was listed by more than 50% of the participant. So this was just a general description. And then they have also written, like, we have used a method called salience analysis. Smith and Borgatti. Borgatti has done a lot of work like Anthropac. So they have done to identify the most salient characteristics among young women in each region. First, for each participant, we determined the salience of characteristic by ranking. And then based on the assumption characteristics, the last was least important. Least important to the participant. So they are just describing the process of this salience index calculation. And then they have given like classification wise also. So I will also tell you how to classify that. So if you see this was they have given the frequency, physical appearance, and all frequency percentage they have not given. They have just given the number, the raw number. Generally, it is advisable that you give it in the form of a percentage. And then they have like given the top 10 physical appearance, because many times what happens, like I was saying, if the list is very huge, let's say in that case it was 76. So it was not possible for them to present the result in the same table. So what they did, they took top 10 physical appearance characteristics based on the salience. So that's why Devjani, I was telling that generally the analysis is done on the salience. So if you arrange that in the descending order, it is easy for you to select those particular items. Am I making sense to all of you? Up till this point? So I think we can go to the breakout room and then we can see the further analysis after you practice once on the visual InfoPack and import the data, show the frequency, the average rank, and the salience index. So how many mentors? Okay, so we are making 2 breakout room. So how was your experience? Could you guys do it? Okay, Dr. Kavya is saying yes. Aditya, how was your experience of the breakout room? Like, could participants share the screen and could do it?
Yes, ma'am, we performed
Okay, there is some audio
in a
issue.
breakout room. Yes,
Can you repeat it? Actually, we couldn't hear. There was some audio issue at your end.
yes, ma'am, we were able to perform it in a breakout room.
Okay, okay. So I think Devjani has written like difficult to develop TXT file. So it is a matter like you can keep one as a reference and then you can enter the data in the next file. It takes time, but again, since the number of participant is let's say 20 or 15, 16, so you will be able to do it. And if you have refined your Excel, then again it is easy. So you do it first on Excel, refine the sheet. We will share that Excel template or sheet with you so that you can see how it was done. And then you can repeat the same process. So coming to the interpretation, because I was talking like we can take the high salience index items and we can represent the result according to that. So what is the interpretation of the salience score? So if any item is having a salience score of more than 0.5, we say that it is a uh, very important or very shared uh, like shared response of what that item was very good. Any item less than 0.1, it is a weak salience index, and generally you should not have that item for pile sorting. You can remove that item for pile sorting. This 0.5 we have discussed, very high salient, but up till 0.1 you can keep. Even the moderately salient and low salience also you can keep it. But the important one, any item which is having less than 0.1, you may not have that as a item as a pile sort. So that's one exercise which we need to see. Now I'll go back to that result which we were discussing. And this is the visual anthropack. Okay, this is the this one was. So you can do subgroup analysis also. So how you can do that? Right now you can see that this is like female salience and male salience. So if I want to do it gender wise, I'll go to the item, click it, compare groups. Click that compare groups, and instead of ID, I have kept it gender. And here you can compare like frequency and average rank also, but most important is salience. So I've clicked this salience. I'll remove this and I'll press OK. So you can have a table where you can show this overall overall salience also. So this language barrier and mismatch, that was very relevant. According to shared belief of all of you, female and male, you can see the distribution. Similarly, the time constraint was also good, but you can see these three, these four. These four did having less than one, like privacy concern or poor follow-up. So ideally, we have not removed it here, but you may try considering the removing it from. What do you want to say? Okay, yes. If you see the time constraint in consultation, there's a very huge difference. Female has said this as a very important factor, high salient, while men has kept it as a low to moderate, 0.25. Similarly, you can see like patient resistance also, there's a difference between men and women. So similar, you can give your result subgroup wise. For example, if you see this article which I was discussing, that physical appearance, here also you can see they have shown the salience zone wise. So if you see, they have divided, the subgroup analysis was done zone wise, like central, north, northeast, and south. And there's a difference, like you can see, it was so high, 0.97, 0.95. These all, the top 10 was like shapely, white skin, bright facial skin, oval face, skinny, high nose, bridge, white pink skin, big eyes, bright skin, and flat belly. So these 10 were the physical experience which ranked uh, the top 10 in the physical appearance of women in Thailand, right? So this is how you can also do the subgroup analysis using the option of this one. Go to item and then compare groups. Then you can do that. Is it all right? Is it okay to all of you? How we can do the subgroup analysis? Okay. Now we'll go to the pile sort. So I'll close this. So we discussed this. This was again the same free list data. And you have already done that, all the thing. Now, how to proceed further after this free list analysis? So like I said, you can remove the list, which are those items which are having less than one salience index, and then you can review and interpret the final list. And you can select a new set of sample, and the sample size for the pile sort is slightly higher than the free list. So let's say in free list, we talk like at least there should be 20. That's the optimum sample size. For pile sort, it is 30 or more than that. So you review and interpret the free list result, and you can keep the top, only those items which are having salience index of more than 0.1, and you can identify those core items within the domain, and then you can compare, like comparison we have seen, compare finding across the gender. Now, what is a pile sort? Basically, pile sort, it is a method which is used to group items from free list into categories based on the perceived similarity. So we give, like the way we have asked you people to do it. Similarly, you will also be doing it. Create a list, final list, give that list to the next set of people. And this pile sort, again, this helps to uh, understand how people organize item, or how, on what basis. And that basis you don't ask actually, because many times they don't know. But of course, if you are following it up with the focus group discussion, you can again try the way they have done the Thailand study, because they have, after pile sort, they have done FGD, 3 to 5 FGD, to understand why they have kept those items in a particular domain, or again clarifying the meaning or what other perception they have. So that you can do. So now how this is conducted? So you say you can select the items from the free list to do the pile sort exercise. You provide the participant again with the cards or piece of paper. So it depends. And generally it is said that if you read that book, they say that you can put pictures, like if something abstract is there, you can write the name. But initially they did pile sorting with, let's say, animals or fruits. So they said that rather than putting picture, it's better to put the names, because that is more helpful. So you can keep all those items on a piece of paper, and you can ask the person to make it pile, or how they will organize that pile. And then you can enter that data in the TXT file. We will show you how to enter that data, and you can uh, ultimately again import or open that file into the Visual Anthropack, and it will give you the analysis. So like after the exercise which we have done, you may get data like this. So let's say this is the participant 1 data. This is the participant 2 data. So participant 1 has kept in the pile 1, like through 2, 3, 5, 7 item. Participant in the pile 2, 4, 6, 8 and 10. in pile 3, 9, 11, and 12. And the participant 2 has kept like in pile 1, 2, 4, 6, and 9. So if you see the 2 and 3 item, so 2 and 3 item, it's kept in pile 1 by first participant, and then in participant 3 has also kept it in the pile 1. And if you see the pile, the participant 5, he has also kept it in pile 1. And participant 6 has also kept it in pile 1. So that means if you see, there is some shared similarity between the item 2 and 3, because out of 6, 3 people are, 4 people are keeping the item 2 and 3 in one pile. Similarly, 4, 6, if you see, 4, 6 is done by this participant 1, and then participant 4 also, and that's it. So these are like the data which you might get like this. Then how you have to move further? Again, you will enter the data in the txt file. For just to understand, we are showing you with Excel, because in Excel it is a very tedious task. But we wanted to show you the proximity matrix. What is the proximity matrix? Basically, how this analysis is done. So the closer it visualizes these pile as a close distance. So the distance between, if you see this, these items. So if the software automatically assigns a distance in the background. So the distance will be from between 2 and 3. It will be less as compared to the distance between 2 and 13, because they are not in the same pile. So on the basis of this, it calculates, basically it is done on the basis of distance. And that distance is calculated by the software the way you put the things in the pile. So we are showing you in the Excel. So suppose how it is done in the background. So how it is done, let's say these are the 14 list. So you write the 14 list in the row and in the column, both. You don't have to do it. How Anthropack is doing it in the background, that we are showing it. So this is done in the background. It writes it in the column, and it's right in the row, both. Now, for simplicity, instead of those names, we have kept it like this: 1, 2, 3, 4. That means it is the free list item 1, 2, 3, 4, like this. Okay. So for example, this matrix will represent basically the co-occurrence. That means if someone has kept 2 and 3 together, so here this 2 and 3, I will put a 1 here, because this 2 and this 3 is kept as 1. And I will keep 0 when they are not kept in the same pile. For example, I am explaining this with the help of this pile which was done by the participant 1. Okay. So just keep your eyes here on the screen, because if you will understand this, it is easy for you to understand the individual proximity matrix and the aggregate proximity matrix. So let's say the participant 1 has kept, I am explaining this for pile 1. So he or she has kept the list 2, 3, 5, and 7 in one pile. So how it will be done by the Anthropack? This is the item number 2. So with this, wherever the 3, 5, and 7 are, it will put it as 1. That means they have kept these two items together. So if they have kept these two items together, value of 1 will be assigned. For rest, value of 0 will be assigned. Like for pile 2. For pile 2, if you see 4, so just select the first one. So this is the 4. Now they have kept 6, 8 and 10 with 4. So if you see, this is 6. So here it is 1. 8. Here it is 1. And 10. Here it is 1. Coming to the third pile. 9, 11, 12. So select the first list. So this is 9. So with 9, 11 and 12. So if you see 11, it is 1. If you see 12, it is 1. Then again, pile 4, 13 and 14. So 13, if you see the pile 4 with 13. So this is 13. So with 14, it is 1. So similarly, like if 14 is there, so with 14, you will mark 13 also as a 0, reverse. So like with 12, you will mark 11 and 9 also. So 11 and 9. So this is how it is populated in each of these cells. Am I making sense to all of you? Yes? Can I see the chat? Okay. Do you use significance calculation of the salience index? That significance calculation is only like more than 0.5 or it should not be less than 0.1 to let that item to be included in the pile sort. And that's the only significance calculation, Antonio, which we use in case of a pile sort. Is it okay? Okay. So this is the individual proximity matrix. Similarly, there will be proximity matrix for all the participants. So there will be, like, if there are 16 proximity matrix, the Anthropac calculates or it drafts the proximity matrix in the background. And then it superimposes all the proximity matrix and calculate the average of that, which is known as the aggregate proximity matrix. For example, if these are the 3, like P1, P2, P3. So if I have to calculate the aggregate proximity matrix, how it will be done? Aggregate will be, if you see, for, let's say, for item 2 and 3 together. So this person has said it 1, this person has said it 0, this person has said it 1. So the aggregate will be 2. So that's why you will see here 2 for 2 and 3. Right. How many total of the participant have kept these 2 and 3 together? That's the aggregate proximity matrix. But again, if we are using the Anthropac, you don't need to do all these calculations and it is automatically done whenever you just open the TXT file in the Visual Anthropac. So Visual Anthropac, in a way, you can say analysis is nothing, but the only important thing is the data entry. So how this TXT file will look, again, you can see here. We'll go to the TXT file. So the way we have written the star title and then star item data, then again here star respondent data. So here we have to enter the item as well as the respondent. And then you have to enter the pile sort. So if you see, this is your first item data where you will be writing what is 1, 2, 3 to 14 and write it like this in the double quote. Can you see? You have to write because it is in Word. So anything in text, you have to write it in double quote. Again, the new set like respondent data star respondent, P1, P2 to P6, age and then address and put it like tab here. That space is with the help of tab. Then again, since you are starting pile sort, so you write star pile sorts, because remember in free list also, we have written star free lists S. So, and then again, you do it for the respondent 1, P1, respondent P2, and do it like this, pile 1, and this is like colon. And then write 1, 2, 3. Don't put comma. Only keep entering the number. It will take these spaces automatically. So we have shared the file. You see and you just emulate the way it's been done. So if you open the txt file in the Anthropack, pile sort app, because Anthropack has got a free list app also. Anthropack has got a pile sort app also. So you need to open the Anthropack pile sort app. It will give you an individual proximity matrix and it will give you an aggregate proximity matrix. So after we get the proximity matrix, the multidimensional scaling that you get automatically. And then if you need to do the cluster analysis, then you can do the cluster analysis to understand the underlying cultural model. And this is the MDS where there is no, like that outline is not there. And here you can see a outline. So we'll see how to do that in Anthropack. So I'll go back to the visual Anthropack. So this was for the free list. I'll close this. I'll go to Anthro. If you type Anthro, I'll click on this visual Anthropack pile sort. Click on this visual Anthropack pile sort. So you can just see this is the visual Anthropack pile sort. Before we enter the data, I'll just show you the actual file and how it looks here. I don't know how many Anthropack got opened. इसका नीचे ही आ ही नहीं रहा. So this was the free list. If you see, this is the pile sort data. So the pile sort data, you can see the title of the data, communication barrier for chronic disease, item data ID, again in the double inverted comma, which we have seen. And if you see the respondent data, so we have written like, we have assumed randomly because we did not ask the age and the gender. So don't consider this is just hypothetical, all the ages and even the gender. By name, what we could make out that we have kept. So this is the gender, age and designation. We have entered it with the help of tab, like tab on your typing board. Coming to the pile sort, this is like, again, I said this. So you can see here it is neatly arranged here. I did that mistake. That's why I am asking you to pay attention. So if you see, it is arranged neatly here. Gender is in the column of here, all female here, all age here, and designation like faculty resident like this. And then the individual pile sort of each people here, like pile 1, 2, 3, 4. There are people who have made 3 piles. There are people who have made 5 piles. So depending on that, we have written, there are people who have made 6 files. Like Priyanka has made 6 files. And again, Ashwati has also made 6 files. So this we have entered. Now, I'll go to the Visual Anthropack file sort. File, open. And this is file sort. You can see the file. So it is yesterday's 27/11, 7:31. I'll open this. So now if you see, we'll start from this. So this is your text data. So this is the same, the way you have seen in the txt file. But if you see this respondent data, what is your comment? Is it arranged?
No.
Okay, but again, no need to correct this, because what I did when I got this sheet, I corrected this. Means I have put all the F in one column. I have put these age which has come here, here and here in this column, and designation like it is to and fro, here and then here in the one column. So don't arrange this here. No need to do that. Then it will not read, because in the txt file, I have shown you, it was neatly arranged. Again, I'll show you that txt file. Wait. If you see, in the txt file, it was arranged. Can you see? Here? It was arranged. So when you import a file, and there, if you see that it is appearing a zigzag, like this, it is the Anthropack, no need to correct this. You come to individual item attribute matrix. And if you see that all items are enabled, yes. All items are enabled, yes. And all respondents. This I attribute matrix is the item attribute matrix. That means it shows that all items are included in the analysis. Respondent attribute matrix shows that all the respondents are enabled. So you can see all the respondents are enabled here, okay? So that's why no need to correct that column, even if it is zigzag. Female is in name and age is in gender, that's okay. Because when you put that initially in the txt, it was well arranged. But no need to correct that. If you see that in the respondent attribute matrix, if it is arranged like this, then it is okay. So you need such sort of interface. Now coming to the item MDS. So this is the item MDS. This is the multidimensional scaling. It has kept 5 and 6 together, 14 and 19, 8 here in this thing like that. But we go from the MDS to the cluster analysis. So for that, what I will do, I will go and click this item. So I want item level cluster analysis. So this is, we go to the cluster analysis, and generally maximum cluster you choose as 5, and then you can click and see. And the clustering method which we use is the average link. That is by default. No need to select any other option. Here if you see, it will show you single link, complete link, but take the average link and press OK. So if you press OK, it will show you, if you see the partition, this shows the partition here on this tab. So this is telling you in one partition, but you select, you start seeing it from partition 5. So if you click partition 5, it will show you like 5 partition. If you click like 4 partition, means you want 4 groups. So now in 4 groups, you can see clear cut, although it is a 2-dimension. Because for this thing, to see it more clearly, you need 3 dimension. But Visual Anthropack gives you 2-dimensional. So this tells that if I keep it at 4 because it's a neat structure in 2 dimension, then I can say that the shared item by the people who were the respondents, they have kept like 8, 9, 14, 5 and 6 together, 4, 7, 5 and 10 together, and 3, 12 and 11 together. You can see this, what are these items, since we have written here by the number, individual item, because individual item if you write it will be very clumsy, that look. So this is your cluster analysis. And if you wish to see the respondent cluster analysis, then you see the respondent, go to cluster. Here also you can click on OK. And then you can see if I select 4 or 3, let's say I select 3. So you can see like these people are together, and Rini and Tanaya, they are like different. Their thought process or they are different from this group. If I share 4 partition, then again you can see that Rini and Tanaya, they are they have their own way of doing it. Kavya, Manju and Ashtami, they are into one group, but rest all other, they are into one group. So you can also see, I mean, I cannot call it as a this thing outlier, but they may be your case study, like the people who are not belonging to this, and you can go and talk to them individually regarding their way, how they have kept and why they have kept. Just for example, okay, so this is the way we do the pile sorting and the MDS and the cluster analysis. So I think we may go to the breakout room again to practice this, and then we'll come and again do some more on this pile sort and MDS. So 2 breakout room.